So severe OCD will have a good response to TMS. So what we usually do is once the patient comes in, we do a Y box. I'll explain this a little more detail later on in the talk also. But just to answer your question right now, yes, we do have good response rates even to severe OCD. So the thing with OCD is, I would say it's probably not wise to use the word cure for this. It is more of a manageable condition because it tends to have its own remissions and relapses. And it's not like a common cold or a fever or malaria or dengue where you can have a definitive cure for it. But it's also not like diabetes and hypertension where you will have to take medicines lifelong. It's somewhere in between. So it is definitely a manageable condition, and it does really help. So what is OCD? So I'll start off with going from the basics. I'll walk you all through what OCD is, what are the different types of OCD. Then we will come to the various treatment aspects. So what is OCD? It's called Obsessive-compulsive disorder. A lot of people do use it fashionably. Let's say if somebody they know is a bit of a neatness freak or something like that, or they want everything to go in order, they do sort of say this is OCD, I have OCD and all that. But that's really not the right term. OCD is more of a state, whereas where it comes and goes. Whereas what people usually in common parlance use OCD for is to say that somebody is having a personality trait which involves specific neatness and meticulousness, sticking to schedules, which isn't really OCD. What we call those traits as obsessive-compulsive traits, and if that is really interfering with the person's life, we call that as an obsessive-compulsive personality disorder, OCPD, not OCD. So what OCD actually is, so you have two terms in the name itself, obsessive-compulsive disorder. So what is an obsession? An obsession is where you have, let's say, a persistent intrusive thoughts or images or impulses. So an obsession doesn't necessarily have to be only a thought. An obsession can be a thought, an image, or an impulse, and can come in many other forms. So this tends to have a feeling, gives the person a feeling that they are not able to control this, and they feel that it is really not possible to think clearly because these thoughts keep coming. So there's a distinction you can make here. So Amir Basha, I will come to the treatment aspect later on in this talk. Yes, it is possible to live a normal life with OCD, with Deep TMS, with medication, with psychotherapy. We will come to that towards later end of the talk. I'll just give an introduction to what OCD is to the general audience who are joining us. So as I was saying, obsessions can be of various forms. They tend to, you can differentiate them in the sense that normal thoughts are thoughts that we want to think about, whereas an obsession is a thought that a person doesn't want to think about, but it still keeps coming in. So the sort of repetitive intrusiveness that we say. And because of these obsessions, a person can then feel secondary emotions. They can feel annoyed, they can feel irritated, angry, they can feel sad, anxious. So how do you deal with these emotions, right? You have certain obsessions and then you have certain emotions, and then comes the third part, the behavior. So compulsions are these behaviors that a person does to deal with the obsession and the emotions, the feelings that are produced by these obsessions. And so these compulsions can be visible in terms of a mechanical act, such as doing something repeatedly, such as washing your hands, taking baths multiple times, let's say saying a prayer multiple times. Or it can be things which you cannot really see clearly externally. It can be like a mental counting just a mental prayer instead of physically folding your hands or prostrating. So it can be mental lists, counting numbers. So these can be different forms, compulsions also. Similar to how obsessions can be images, thoughts, impulses, compulsions can also be different. So compulsions initially start in terms of trying to deal with these obsessions, right? Let's say a person has this fear of germs, where they feel that if they touch something, some germs are on their skin surface. But the compulsions are not necessarily directly related logically to clearing this problem. So if I were to have germs, I would probably wash my hands with soap or water, and I would understand that germs are everywhere, right? It's not that you can really have a germ-free environment. You can't live in a bubble. But the thing with OCD is there is some fault in the logic that is being applied, even though tangentially they may be related, the action and what they think that action will solve, but not really. In terms of actually reducing problems, that doesn't happen. Problems tend to worsen with the compulsions. So there is a sort of faulty logic involved in this, where a person does something repeatedly, hoping that the obsession would go away, or hoping that the anxiety or the negative emotion associated with the obsession would go away. But in doing these compulsions, it's the opposite. It sort of reinforces these obsessions and the behavior related to this compulsion. So it sort of keeps getting worse and worse. That's why we need to sort of put a hold to these compulsions, and I'll walk you through how we go about doing that later on. So just to give you a little more detail on these types of obsessions, right? You can sort of divide obsessions into 4 or 5 domains. So the first, some of the most common symptoms of OCD is the contamination domain, whereas a person usually gets obsessed with things which are quite hard to avoid, such as germs. Like I said, germs are hard to avoid. They're everywhere. From the moment you're born, you're exposed to germs. You can't really live in a bubble. But the sort of danger or the threat that the person feels, which is being posed by these germs, is overblown. Though you would see, there are about close to 7 billion humans, and we all sort of go around with germs, sort of bathing in germs, but still we go on. But OCD sort of takes this problem and sort of magnifies it to the point where a person is not able to move on away from germs, right? Even though rest of them are. This sort of thought keeps coming. Apart from germs, the other contamination objects can be, general pollution. People can be obsessed with the thought of being exposed to radiation, to radio waves, to other body fluids, chemicals in the environment, chemicals at home. And the faulty logic here becomes that just because I touch something, even for a fraction of a second, somehow there is some exposure to this, there's sort of this chain of contamination, and then later on when I go touch another person at home, or I touch another object, this sort of contamination spreads, and then this chain forms. So then they are sort of spend a lot of their time thinking about these objects, how to get away from contamination. Or of course, if they cannot get away from these contaminants because they're all around the environment, then they start restricting their activities to certain ways, forming rituals on how to avoid certain things, or even if they are exposed, then they come up with a ritual on how to clean themselves in a stepwise manner. And a lot of their time sort of is spent in either worrying about the contamination, on how to avoid it, or performing these rituals post contamination to get away or to reduce the chance of something bad happening from this supposed contamination. The next domain is the pathological doubting or checking. So again, I would like to sort of differentiate normal checking from an OCD checking, right? Let's say you want to go out, we all do sort of check once or twice if we have locked the door, maybe is the geyser off, is the stove off, But with OCD, the sort of persistent doubt keeps lingering to the point where a person may go away on a trip and then halfway through the trip may sort of track back home, thinking that they have not really locked the door or the geyser or the switch. And this they can and even if they're at home, right? Let's say you want to go to bed at night, you lock the doors, you go to your bed, and then you wake up again. And this person goes to the door again, checks, and then they go back, and then they come back and check again, and then they go back and they come back and check again. Right. So is overthinking to a form of OCD is a question. I will come to how do you differentiate OCD from other conditions. If we could wait for a few minutes. I will talk about how to differentiate OCD from other normal conditions and other diseases also. So the thing with pathological doubting or checking is, if I were to give you an analogy in layman's terms, let's say you are on like a game show where you're going to win $1 million if you answer the question. Let's say there are 4 options. Let's say you choose an option, right, A, and then the host asks you, are you sure this is the right answer? Are you sure you want to lock this? Are you sure there's nothing else? Are you sure you're willing to risk everything on this locked option? That's sort of an example of how OCD thinking is. Let's say I lock the door, I go to bed, but then I have this thought: am I sure that I've locked it? Am I sure that I want to believe that I've locked it? Am I sure that I can really believe this evidence that I've seen with my own eyes that I've locked it? Why not just go check again? Do I really want to risk somebody coming in and then burglaring my house on one thought of or this belief that I have locked it? Let's go check again. So this sort of thing keeps happening to the point where a person is not really allowed to sleep also. They keep getting, so that's a pathological doubting or checking that happens. The next sort of obsession can be an intrusive or a forbidden thought. So this can be in terms of either religious thoughts, right? Let's say you're trying to pray and then you have a thought of God or the gods, or in awkward positions, or you can have this image. A lot of people find this very embarrassing. We also call these as sort of blasphemous obsessions, where you hold somebody to such a high regard and respect, but then you have these negative thoughts, you have bad words being associated with them, and then you can't really deal with this, right? And it may sound funny or it may sound strange. Why are these people reacting this much to a thought like that? But can you imagine, let's say your belief system is built around going to heaven and then being judged once you die, and then every moment you have these bad thoughts or bad images by the eventual judge, right? And then you're worried, like, I'm thinking these bad thoughts about the gods and other divine entities, and what's going to happen later on? Like, will I get into heaven? Will I be pushed into hell? So, even though these may sound, funny or something to take light, for the person themselves, this can have, or these can seem to have huge consequences, right? So these are sort of things that you need to really not tell the person it's okay, these are just thoughts, these will go away. The person does really feel anxious. The other sort of forbidden thought that can come is the sort of sexual thoughts, which can involve other family members. These can be close relatives, and this can be very embarrassing for the person to really open up. And these are probably one of the most distressing ones, where the person really feels guilty, starts blaming themselves about having these thoughts, and it's really difficult for somebody having these sort of sexual obsessions, especially about family members, to really open up to the same family members to help them with treatment, right? How if you were to put yourself in those shoes, like, how do you really approach somebody and tell that you're having these thoughts about them, and you're not really sure if these are actually thoughts, because nobody has really told you that this is a disease or this is OCD. We do have a lot of patients who go years with this feeling of guilt, unable to really understand why these thoughts are coming, who then sort of have a huge relief and improvement with treatment. So the last sort of obsession that I want to talk about here is the sort of symmetry obsessions, or the need to order. where a person will feel the need to have everything in a right manner, and they'll keep reordering things. Again, this is something that you see in TV shows, you see this in movies, where a person is said to have OCD just because they want everything neat and arranged. But again, that is a very mild way to put it, and that again, like I said, these sort of things that you see on TV shows are more along the terms of obsessive-compulsive personality traits, not necessarily the OCD disorder. An OCD disorder in this case of symmetry would be somebody spending 6 hours, 7 hours, let's say a day, rearranging the things on their table just because it doesn't feel right. So the sort of just right sensation is another thing that we talk about with OCD, where a person, let's say, switches on light repeatedly until it feels right. There are other types of OCD obsessions also, such as especially centered around this not feeling right. You could sort of have somebody walk across a doorway and let's say they do it on the left foot, then it doesn't feel right, so they go back, then they do it on the right foot, it doesn't feel good, so they keep going back and forth doing this for many minutes or hours. There are other things, especially with students, that you see, let's say you're in college, you're taking notes, and then you feel this need to reread or rewrite, right, to the point where you sort of forget that there's a class going on and people are moved on. You keep rereading and rewriting the same paragraph over and over again in class. This is also something that we see with students. So these are all, so what I've sort of shown you is what are the sort of spectrum of symptoms with OCD. There is also a spectrum with something called OCRD that I'll talk about later on too. It's not just OCD, there are other disorders in this, such as hair pulling. A person may continuously feel the need to pluck their hairs out. There's also body dysmorphic disorder, which sort of comes within this OCD spectrum, where they feel a certain body part is not really good looking enough, or they feel the need that it has to be altered, and then they get repeated surgeries for it. There's also skin picking disorder, excoriation disorder, which also comes under the spectrum of OCRDs, where a person may repeatedly keep picking their skin until it bleeds and forms an ulcer in multiple body parts. So that is what OCD is. So why does OCD occur, right? So it's not because of a sin that you've committed in your past life, or it's not because of a punishment. A lot of people may associate this with having supernatural explanations, especially if you're having these religious sort of obsessions that I mentioned, and trying to look for religious or spiritual cures for that. Though that does help in a way, that's not a curative action. So OCD, from what we understand, is primarily related to deficiency of serotonin in the brain. Serotonin is a chemical. You might have heard about this serotonin along with something like dopamine, norepinephrine. So serotonin is a chemical in the brain which sort of associated with these symptoms. And the drugs we all give, drugs in the sense medication, these are medicines to increase serotonin levels in the brain. These are commonly called SSRIs. You might have taken something called fluoxetine, you might have taken escitalopram. So these are sort of the class of drugs that we prefer with OCD. Dopamine is also sort of associated with OCD. Sometimes you may find your clinician prescribing to you a drug like risperidone or aripiprazole. If you're sort of the person that likes to look things up. So it is serotonin, a little bit of dopamine also. Glutamate is another neurotransmitter that has been shown to be associated with this. So why does OCD occur? Where does OCD occur in the brain? If I have to sort of tell you about it, maybe I can show you a small picture about OCD. So this is something called cortico-striatothalamic cortical circuit. So you have the cortex, you have the thalamus, the striatum. So what we know from research, from brain imaging studies is there is sort of an imbalance in the activities in these regions, and these are the targets of our drugs too. also targets of TMS, which I would like to focus on next. Apart from TMS, you also have traditionally the exposure-based psychotherapies. I will sort of walk you through these. So, with medication, what can you expect? It's going to be about sometimes. Some of the things that the difference between, let's say, depression and OCD is the amount of time it takes for a person to respond. Sometimes with OCD, with a single drug, guidelines recommend trying it out for up to 12 weeks. So I know that's a really long time for somebody with OCD, with the sort of symptoms, to deal with them. With medication alone, sometimes it can take up to 12 weeks, a trial of 12 weeks at a good dose. But even then, sometimes people don't respond to the first drug, so we may have to go to another drug, which is again another 12 weeks, right? So that is about 3 months plus 3 months. It's about 6 months until you really know you've tried 2 good drugs and let's say you're not responding. So it is a long time, and it's perfectly understandable that people cannot wait that long, and this sort of does lead to changing doctors often, especially with OCD, where you wait for a month. It's all fine and good when somebody explains it to you, but then if you're really suffering from OCD, it just doesn't come across. When the doctor tells you please wait, it's sort of human nature. You feel maybe there's something going wrong with the medicine, maybe you're not getting the right medicine, maybe you want to try something else, maybe your luck with another doctor would be better. So this does happen. It's perfectly understandable, but I would say that you should probably stick to the primary treating psychiatrist and wait, because OCD is a condition that takes quite a long time until a good response or remission is seen. So this can be altered. You do not need to wait for 6 months. So what we have is something called TMS, transcranial magnetic stimulation, and the response rates we are seeing with that is about 2 weeks. A good 50% reduction in your OCD severity scores in a matter of 2 weeks, instead of waiting for, let's say, 3 months with medication alone. So I will talk about what TMS is next. So what is TMS? I'll just show you another picture here on what TMS is. So this is what actually happens when you're having TMS. So this is something called Faraday's law. You might have heard of this in your 11th standard. Basically, electricity is passed through a coil. A changing electrical field produces a changing magnetic field, and a changing magnetic field produces an electrical field. So this is Faraday's law of electromagnetic induction. We have here different coils at Asha Neuromodulation Clinic, which are for specific conditions. For OCD today, I'll focus on the H7 coil. So the H7 coil basically has a certain configuration to target these areas which have been implicated in OCD. The previous picture that I showed you, the corticostriatothalamic cortical circuit. So as a part of this circuit, we target 2 main areas. So here is the anterior cingulate cortex, which is sort of one of the control centers of the brain, which deals with controlling the emotions in terms of planning, in terms of putting together information from multiple areas, emotional salience, what we call. Also the medial prefrontal cortex. So the medial prefrontal cortex, again, it is involved in executive functioning in terms of deciding how much emotion, in terms of emotional regulation. So this sort of controls your limbic system, which is your emotional centers of the brain. So in OCD, like I mentioned, you have these obsessions, you have these thoughts, and these sort of thoughts produce an unusually dramatic emotional response. You really feel anxious. People around you don't understand why you feel anxious about something that they feel is very small. So these are sort of the regions which are misfiring in the brain, which produce these symptoms, right? And what we are trying to do is directly targeting these symptoms. So basically those coils have electricity going through them. This produces a magnetic field, which then produces an electrical change in these specific brain regions. So there is no direct contact with electricity. It's a padded helmet which is placed on your head. It's very comfortable. and the only thing you will hear is a little tuck 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 sound as the fields are being generated. What response? So of course nowadays people do expect to be shown the response, right? The evidence is in the pudding. What evidence can I show you? I'll show you data from about the last 1 year that we have had at our neuromodulation clinic. About 300 patients in total who are suffering from both depression and part with OCD. There's about 130 patients with OCD. I'll just show you their pool data. So what actually happens when you come to us is basically we quantify your OCD score. So when a person asked what is a severe OCD and can I respond, so this is something called a Y-box questionnaire. Basically we ask you what sort of obsessions do you have, how often do you feel them, is it like less than an hour, 1 to 3 hours, more than that, how much in control do you feel with your obsessions, do you feel you're able to control these, are you able to resist these obsessions, or do you feel there is no control at all. Similarly with compulsions, how much time you're spending with these compulsions, how often do you try to control these compulsions from taking over, and how much control do you feel. So based on this we'll sort of give you a score, and this is before the treatment is started. After the treatment is done, we'll again perform this questionnaire, and then we'll come up with a score. So this is sort of pooled data. I'll show you another picture here about the pooled data. One caveat to this is, see, statistics are for populations and not for individuals, right? So some people respond really well, some people not so much, some people in between. So this data is sort of pooled. It doesn't necessarily mean that your experience is going to be as bad as somebody else, or it's going to be, you may have a really wonderful response. It's all individualized, and you can discuss with your treating psychiatrist about whether you are a good candidate for this treatment. So what we do know is from the last 1 year is there is almost a 50% reduction in the scores. Let's say you have an average score of, let's say, 26, right? It does come down significantly within a period of 14 days. If you remember, I told you that this treatment with OCD, just with the medication titration, it can take up anywhere between 3 to 6 months in order to see a good reduction in the scores. With TMS, with our experience in the last 1 year, what we have seen with an Indian population here, from the patient populations we do work with, is that you're seeing a reduction in about a 50% reduction in 14 days, which is, let's say, twice or thrice as fast as what you may see with just medication. So TMS again is not a new technology. It's been around since 2017. Relatively new technology. It's not old. Deep TMS. TMS is old. It's been around for decades. But the Deep TMS technology that Asha Neuromodulation Clinic specializes on, it is quite recent. And the machines that we have are cutting edge of Deep TMS technology. And these are significantly better than the older butterfly coiled TMS coils that are seen. So these are quite new Deep TMS machines, and the responses we see with this is significantly better compared to the older generation of TMS coils. So we do see a good 50% improvement within 14 days, and you don't need to take my word for it. The evidence is quite clear to us, and I hope from the evidence that I've shown you, it's quite clear to you too, that we do see a better response, and you don't need to wait as long as with medicines alone. So apart from medicines and TMS, so how else do we go about treating it? What we do during our sessions is a little behavior therapy. Traditionally with OCD, there is an alteration in the behavior, right? I told you there is a thought, which is the obsession. There is an emotion, which such as anxiety or sadness or anger or irritability, and then there is a third part, which is the behavior, which is the compulsion that a person feels compelled to perform. So there is an initial association. Either the person believes that the compulsion they're performing can resolve this anxiety, and they so continue to perform this. and then these two things become associated, right? It's something like, let's say, at 6 o'clock somebody calls you up on your phone, a relative, your parent, and then you sort of expect this 6 o'clock thing to keep happening, right? So you get conditioned to this, you sort of expect this. Or let's say you have dinner at 8 in the evening, and then one day there's something late with your dinner being served, and then you get cranky, you get your hunger picks up, and then you start picking a fight maybe. So this is conditioning, to put it simply. Something that happens regularly at the same time sort of become associated mentally and emotionally with this. So that is the thing with OCD also, where let's say you perform something hoping it helps. Maybe initially it does help because you believe it will help. Let's say you wash your hands because you feel your hands are contaminated, and then you feel a sense of relief, right? And then that may be true. Theoretically, yes, your hands are getting clean by washing. But then when you start repeatedly doing it to the point where your skin starts breaking down, it starts drying up, it starts bleeding. Some people with severe OCD can sort of keep washing their skin until the muscles are visible, right? At that point, what are you really doing? Are you really trying to keep the germs away? But you're so conditioned, your brain is so conditioned to believing that soap and water and sanitizer helps removing germs. It doesn't occur to the person that they have literally lost a layer of their skin, right? So the conditioning is so severe that no matter what evidence is given to them, they are not really able to move on from this thought. So what we actually do during behavior therapy is expose the person to these feelings or the situation that they're afraid of, and then we prevent them from doing that compulsive behavior, right? So this again acts in a cognitive behavioral model, something called CBT, and exposure response prevention therapy, where you have a cognition, which is the thought, you have the emotion, and then you have the behavior. So some of the cognitive factors which can interfere with improving is, let's say, something called thought action fusion, where let's say if I think it, that means I have done it. Let's say this thought comes that this sort of blasphemous thing that I was talking about. Let's say some sort of blasphemous thought comes, it immediately to the person feels that they have committed a great sin, right? A thought is equated to an action, and they're not really able to dissociate thinking, feeling, and doing. The other thing is sort of increased responsibility to things out of their control, right? Let's say we all go out, we go on the bus, we go on trains, we touch something, and then you touch your phone or you bring it back home. So some of these people may feel personally responsible for actually bringing the germ home. Let's say if somebody gets sick, or they feel somebody will get sick, and they have this exaggerated sense of responsibility that because of them doing something like this, somebody else is going to fall sick. So these are some of these cognitive changes that we really sort of need to work on. So how do you really go about doing this, right? So during our therapies, we give certain exercises to the patients during TMS also. So there have been some papers, recent papers published that activating these circuits during TMS therapy and then applying TMS at the same time does tend to really help with decreasing these symptoms, exposure during TMS therapy itself. So these exposure therapies traditionally are done not with TMS as a separate modality itself, where you would meet with your psychotherapist, psychologist, who's trained to sort of administer these therapies. So we do have in ANC, Asha Neuromodulation Clinic, we do have psychologists here, we do have psychiatrists, we have TMS specialists. So based on your specific symptom profile, we can sort of come up with a plan on which will suit you best and how to combine these three to give you the fastest treatment, right? So with psychotherapy, what people usually go through is we have a few sessions, introductory sessions on what we are going to do what we say, building a therapeutic alliance, and then we talk about these cognitions, these sort of distorted things that I mentioned to you, the sort of thought act and action fusion, taking excess responsibility. We sort of explain this to the person. Then starts the behavior component, right? So the exposure in OCD can be of three types. You can be exposed to, let's say, what you're afraid of, right? Let's say you're afraid of touching something, right? And then let's say touching a sink. So you'll be made to touch a sink or the tap, and then you are then told to sit without washing or sanitizing your hands. So this is basically breaking that obsession and compulsion, sort of the fusion that we talked about, where the person is conditioned to wash their hands. So initially you will see, if I were to draw a graph, right, initially the anxiety will shoot up because they're being prevented from doing something that they feel helps with their anxiety, but then the anxiety drops down once they realize nothing catastrophic that they had imagined would happen isn't really happening. So the anxiety does reduce. So other ways to sort of deal with this imaginal exposure, where a person is asked to imagine touching something or going and doing things which would normally really give them that anxiety. The other thing is something called an interoceptive exposure, right? So getting used to these feelings of anxiety, maybe you can breathe into a bag, hyperventilate, sort of do sit-ups. And when you do this, your heartbeat increases, your breathing rate increases, you sort of stimulate this feeling of anxiety, and then you sort of deal with this without doing any compulsions. So you have in vivo exposure, interoceptive exposure, and imaginal exposure. So when these are done, and with concomitantly with being exposed to the object of the obsession, the person eventually realizes they don't need to do the compulsive act, that we are really trying to break this. Just because they do not wash their hands or do a prayer or count or rearrange things, just because they are not doing that, it doesn't mean the world is going to end or something catastrophic is going to happen. That is the key to learn, basically. It's something like coming back to the dinner example. Let's say you're not getting food at 7 p.m. It's being moved to 8 p.m. Some days you're gonna get used to it. Eventually, your body will sort of get used to eating at 8 p.m. You may not really feel hungry at 7 p.m. exactly, right? So your body does get acclimatized. Similarly, with OCD, the goal is to get acclimatized to these sensations of anxiety when the compulsion is not being performed. So some of recent studies, like I said, so that is the traditional exposure response prevention. But with our TMS technology, we do offer these exercises during the TMS session itself, so that the exposure and the anxiety builds up during these periods. These regions in the brain are activated, and at the same time, they're being targeted by our TMS treatment. So it does lead to really good response, right? You're somebody watching right now with OCD. What I can tell you is there is a wide range of treatment options available. We do sort of deal with people from multiple severities. You don't need to feel that it's natural to feel that nobody can really understand what you're going through. Nobody can really, though I'm telling you all this, I'm telling you that there is treatment is possible, there is thing, but you may still feel that just, the treating doctor may not have ever suffered from OCD, and so they may not really know how severe it is. But having said that, we do see patients with multiple severities going from mild to extreme OCD, and there is treatment response across the spectrum of severities. It's not just that mild patients will respond better or moderate patients will respond better. Response can come with that, right? So is there a difference between, so I'll start taking some questions at this point. I think I've sort of covered what is OCD, what are the treatment options that we have, how does TMS really come into picture into this. I think we have about 20 minutes. I'll start taking questions if you have any. So what is the difference between OCD and depression? Well, how do you differentiate? So OCD-like symptoms can also occur in other conditions. With depression, what happens is the obsessions or the thoughts that you have, we don't call them obsessions in depression, we call them ruminations. Basically, they are of a character of negative thoughts, mostly thinking bad will happen, people hate me, I'm a loser, I will never get along, I will never do something in life. So that is the sort of obsession, the rumination that comes along, which can seem very similar to an obsession. Whereas with OCD, these necessarily are not associated with low mood or negative low self-esteem. So with depression, classically you have negative thoughts about yourself, about your environment and your future. But with OCD, it can be very random things. It can be repetitive thoughts about let's say a picture of a god, or let's say an image of a toilet, or it can be about the lock in your home. It is not associated with these sort of negative thoughts about yourself, future and environment. That I would say is the principal difference between the rumination in depression and an obsession in OCD. The other difference, somebody else had also asked, how do you differentiate from other disorders? So in anxiety also, people keep thinking bad, catastrophic things. But in anxiety, they're usually anxiety disorders, they're usually worries about everyday life, about, let's say, accidents happening. You may be a new driver and then you may be anxious about getting into an accident. That is perfectly understandable. But with OCD, you will have repetitive images of car crashes or something horrific happening without any reason. You may not even be a driver, you may not even have a car license. It can be just the most random things that happens with OCD. But with anxiety disorder, these are usually specific to your situation. Let's say being the thought of being stuck in a lift, or the thought of having a panic attack, or thought of public speaking, which may repeatedly keep coming, right? But in OCD, these are not necessarily associated with day-to-day conditions. It can be the most random things that keep coming. Right. So there's a question now, how do you know if TMS is helping or the medicine is helping? So what usually happens when, the authority world over which actually says if a treatment is working or not is usually considered to be the FDA in the US. So what we do is something called RCTs, randomized controlled trials. Basically, you take a person who is having OCD, you give them TMS, and another person, something called a sham treatment. This is only done in research settings, not in our clinic. So basically a sham treatment where the coil is placed, but it doesn't actually stimulate the brain, right? It produces these sounds, but it doesn't. So that is done in a research setting so that the person doesn't know if they're getting treatment or not. So what they do find is, even though they put the helmet and the brain is not being stimulated, so the person thinks that they're getting treatment. This is called the placebo effect. So that is how you compare. So comparing to that, TMS has a dramatically higher chance of actually responding, whereas a person with just a sham treatment doesn't respond at all. So that's how you know if TMS works or not. The next step is to compare TMS with medication, right? So you can either do that with not give medicine at all, just TMS, and some patients with medicine alone, and sort of compare the response. The other way to go about this is TMS plus medicine and medicine alone, right? So what in our experience we find is TMS combined with medicine has a better chance of improving in certain populations. Again, it's not necessarily that anybody with OCD will be started on TMS right off the bat, right? It sort of depends on your severity, your life situation, how soon you want to sort of come back to improvement. Let's say in the US, where some of these protocols were developed, US and Europe, let's say you can probably take a few days away from your work. You do get disability benefits. The government actually pays you like a stipend or something like that, to take care of you have social security there, right? So you can afford to go very slow with treatment. Whereas in India, you cannot, right? You take a week away from your work, you're probably going to lose your job. And then you don't have social security. The government doesn't pay you to maintain your lifestyle, right? So you need treatment faster. So what we have done at Asha Neuromodulation Clinic is actually customize some of these treatment protocols so that we don't give them over a span of 30 days is what in other countries over the world they do. We sort of reduce that time within 14 days to sort of give this in an Indian environment for the Indian population. And from what our research that we have done over the last 1 or 2 years is our response rates in a shorter span of time is equivalent, if not better, than what is being done in other countries with a longer duration of time. The treatment that we give does work similar or if not better to a longer treatment span, right? So what is given in 30 days outside, we give it in 14. The response we see is in about 14 days. So with OCD, the TMS treatment is usually given as an add-on. Your clinician may start you on a medication first and then see, and if you are willing to wait, if your life situation is such that you're able to go on with your life, if you're able to manage, that is well and good. You can sort of manage with medicines for a while. But if you really need a quick response, or let's say you have had multiple treatments with drugs in the past and they have not worked, then we can also start TMS. So the specific indication for TMS depends on the person, right? Like I said, statistics are for populations, not individuals. For the individual, it really has to be customized depending upon your symptoms and how your clinician feels about it. So if you're having OCD, if you know somebody who's having OCD, you can ask them to come to us and we'll talk to them, have a consultation. We'll be able to customize what they require. So I hope that answered your question. So this is how research is done long before the regulatory body gives an approval. So you have to show that TMS has worked compared to people who have not received TMS. TMS has worked at least what we call non-inferiority trials, right? If TMS is as good as medicine. So after all these is when FDA actually approves, and once FDA approves for commercial and treatment outside of research setting is where the company really produces these machines, right? So I think somebody else asked, how do you deal with overthinking, right? Can you really change your thinking patterns? Yes, like I said, the behavioral and cognitive things with ERPs, with CBT is how that specific aspect of OCD is targeted. Is overthinking to a form of OCD is another question. Overthinking, is it a form of OCD? So I think it's something like saying all cats are animals, but not all animals are cats, right? It's something like that. Overthinking it's a colloquial word. It can be a form of OCD, but it's sort of very loosely used. OCD needs to have these obsessions and or compulsions. You can have obsessions alone or compulsions alone, but usually they go together. And these overthinking that you put it as should have enough stress or should have enough interference into your life to be qualified as a disorder. Just because at random times, let's say somebody in your house is having a major surgery, or they are sick, let's say they are admitted, of course you're going to overthink this, right? You're going to think about what is going to happen, but that is sort of justifiably understood in that context. So I wouldn't call anything and everything where a person spends time thinking about it repeatedly as OCD. It sort of really depends upon your life situation and the severity and the impairment that you're facing. So I think Amir Basha, I think, has previously asked a few questions. He has this thought that he'll be dead in an accident, and that is sort of coming repeatedly. Morning till bed, this thought is coming. So yeah, that is classically an obsession where it keeps coming and he's not able to deal with this. Medicine, he says, when medicine's not working, will it work or not? We do expect it to work. With Deep TMS, we do expect at least a 50% reduction in your severity scores when you go through this. But if you could sort of take an appointment, come meet us, we can sort of talk to you in detail and help you out. So I think another question was how does somebody deal with a family member who's having OCD? Well, I think one of the thing is to not tell them it's all in their head, it's all in their mind. This is sort of general to any psychiatric disorder, not necessarily OCD itself, where people sort of tend to say, oh, it's all in your mind, with willpower you can change. Sure, willpower is a part of it, but the issue is during these sort of episodes of psychiatric illness, that willpower is something that is deficient, right? It's like if somebody complains, let's say, I've broken my foot and I cannot walk, or walk to the other place. What if somebody comes and tells me, well, all you need to do is get up and walk? Well, that is the main issue here, right? Your foot is broken and you cannot walk. So it doesn't really help telling a person who is having sort of abnormalities with their thoughts that just by thinking better that they will get better, because the problem is that they're having these thoughts. So trying to the solution cannot be the problem, right? So that is something that the caretaker has to sort of understand. So another question is, does TMS have any side effects? So how do you screen for TMS? So TMS is pretty safe. I would say it's probably safer than a lot of medicines in terms of side effects. And the other thing is, nothing under the sun has is perfectly safe, right? Even sunlight can cause skin cancer if you're exposed to it too much. So even sunlight is not perfectly safe. Sunlight also has side effects. So TMS, the people who are perfectly safe for TMS is if you've ever had an MRI, you're probably perfectly safe to undergo TMS, because a TMS is basically a miniature MRI, to put it into layman's terms. It is a similar principle where magnetic fields are being generated. So if you've had an MRI before, you should be perfectly safe enough to get a TMS. Some of the things that we say, things that cannot work with TMS or not compatible with TMS, is probably having a recent brain surgery, having aneurysms in the brain, having a recent major health event like a heart attack, having dental implants, right? So because TMS, like I said, Faraday's law of electromagnetic induction, you have an electrical field, a magnetic field, and then an electrical field again. So if you do have dental clips or implants, again, dental implants and clips have different metallic compositions, right? So different metals have different magnetic properties. These are called ferromagnetic substances. Not all metallic implants are ferromagnetic. So recent stents or clips or metallic implants tend to be compatible with bioimaging. That means they're non-magnetic. So you can check with your dentist, or if you have a bill from your previous dental procedure, or if you have a box that sort of says the specific composition of the metal, we'll be sort of able to help you out and seeing if it sort of works. Even if you don't have these things, you can still come down. We have a specific protocol for this, where we sort of check if your dental clip is sort of compatible with RTMS, where we give a very low dose just to check. If you're having any pain, side effects, then we will not proceed with TMS for you. In general, TMS doesn't have any major side effects if you do not have these sort of major health issues. The other thing is having a history of seizure. So seizures can be induced with medicines also, certain medicines. So since this is an electrical thing, if you're a person who's suffering from seizure disorder, if you have not been on regular medicines, if you have not had your seizures being controlled, then there is a possibility of you developing seizures because of TMS. This is in persons who are having seizure disorder. In persons who do not have this, which is the vast majority of people who they do not have seizure disorder, it is perfectly safe. I would probably say you have a higher chance of the chance of you meeting a road traffic accident when you're out there in the road or crossing the street is probably similar to you having a major effect with TMS, right? Just because there is a remote possibility of somebody hitting you when you're on the street doesn't mean that you don't go out, right? So it's something similar to that. It's pretty safe. provocation, is it necessary while TMS is going on, or only TMS is okay? So it is not necessary all the time. So with OCD, there are certain types of obsessions and compulsions for which exposure response prevention is really helpful, right? Let's say germophobia, where you feel like you've touched something and thing. But there are certain obsessions where you cannot really expose this person to anything, right? Let's say some of these sexual thoughts or sexual images, how do you really go about exposing somebody to sexual thoughts or images, right? So or let's say religious thoughts or religious images of God, how do you really, you can't really show somebody God and then say, you can show them a picture of the gods, which is a sort of exposure response also that we do use. But what I'm trying to say is there are certain types of obsessions and compulsions which are amenable to ERP. Not all of them are. So in that case, it sort of depends on your symptoms. You may be getting ERP with TMS, or you may not. That completely depends upon your treating clinician, your psychologist. But you can sort of ask them about this next time you do go to TMS therapy, if ERP is something that is useful for you. And if the clinician feels it is useful, then they can go ahead with that. Is there a recovery period after undergoing TMS? So what we usually do with TMS is, these are 20-minute sessions. So you get a 20-minute session. You need a minimum waiting period of 1 hour, and then you get another 20-minute session. So when you do come to a clinic, we sort of arrange these timings such that you are spending less than 2 hours of your day here, right? So most of our clinics, they work from 8 in the morning to 9 in the night. Most of our clinics are also functioning on Sundays. So let's say OCD treatment is about 7 to 8 days. So you can come in daily for your TMS treatment. You can arrange such that you take only 2 hours of your, of your life dedicated to TMS treatment, and that's it. There is nothing as a recovery period beyond this 1 hour, I would say, between sessions. I hope that answered your thing. There isn't necessarily a recovery period except for that 1 hour gap between TMS sessions. Does TMS work for every patient? Again, it sort of depends on what sort of thing that you get, the symptom severity and the sort of character of your OCD. But from the data that I showed you a few minutes ago, a pooled response of about 120-30 patients, an average of 50% reduction, right? So there is a good chance that you will be benefited from TMS. But how much? So some people are slow responders, some people are fast responders. So that completely depends on the individual patient. Again, statistics are for populations, statistics are not for individuals. Just because let's say the chance of it raining today is, let's say, 50-60%, it doesn't mean it's really going to rain, right? That's still a thing. So the chance of bad outcomes, again, is not set in stone. If we find TMS is not effective, so what we usually do is, once TMS is started, we talk to you. You will meet a psychiatrist on the first day before TMS is started, 3 days after, and every 3 days once as the treatment is going, and we'll sort of reassess if the treatment is working. We'll go through the rating scales. So if we feel that the TMS is not working, or if there are any side effects, we will alter the TMS settings. So these are customizable, highly customizable. The intensity of the TMS, the duration of the TMS, something called the frequencies. So that is individualized for every patient. If we find every third day when we see you, when we talk to you, as in the clinician, you'll be talking to a psychologist on a daily basis. So anytime you can tell them that if you're having some issues, if you feel the treatment is not working, we will alter it immediately. So what about age, duration of OCD symptoms can be treated completely, right? So OCD is something that happens throughout. So once you get, there are periods, I think there's something I mentioned initially, where OCD is not like fever or malaria or dengue, where it's a matter of days. but it's not like diabetes or hypertension where it is continuous at a full syndromic level, as a full disease level throughout your life. So OCD, mostly people come and go around this, right? So sometimes you may have severity, you take medicine, it comes down. With medicine, it sort of thing, then eventually you may even not require medicine, and then you can be good without medicine, and then maybe 10 years from now you can have some obsessive symptoms. Let's say maybe it's a life stress, maybe you lose a job, maybe it's a childbirth. At those times you can have obsessions again. You can meet your psychiatrist during that time, and again we can get it under control. It is not necessarily that OCD will continue to be at a full severity. Let's say if this is normal, it's not going to be that it's going to be at full severity throughout your life. It is going to it will come down to normal, it may go up, it may come down. So it sort of comes up. There are ups and downs. So there isn't, so again, this is individual, this is for the individual. It can be treated to varying extents. Again, it may not be curative, as you may, I would not like to mislead you in that sense. It is not curative like malaria or dengue, whereas you cure one episode and you'll never get OCD again. You may have these symptoms throughout, coming and going at different points in your life. Some people may never get OCD beyond the first time they get it. They may be really good with treatment, but age, duration of OCD symptoms, I wouldn't say that it is necessarily a bad thing. There are patients who have had OCD. In general, for somebody to come to the doctor with OCD takes years. They may develop OCD symptoms during their adolescence or teenage, but then they may be able to deal with it, right? When you're a student, you're in college, you don't have much responsibilities, you can sort of avoid things which give you these obsessions and then go on with life. But then once you're an adult, eventually you cannot really avoid these things anymore. At that point your OCD sort of, people around you may start noticing these things. At that point you really do require treatment. So a lot of our patients go years of full syndromic OCD before coming to the doctor, and having a long untreated illness is not necessarily associated with a poor treatment outcome, right? There is no, I would say, do not be nihilistic about this. Just because you've had a long period of time where you've not been treated, there's always hope. We can always start you on medicines. And like I said, for most people, I would say with OCD, it takes years for them to sort of realize that they have had OCD and start treatment. And most people with OCD do respond, right? So I wouldn't say necessarily that longer duration, if you have not taken treatment, means you shouldn't start treatment or you should feel nihilistic about it. Please meet your clinician. Doesn't matter at what point of time that you're meeting them. All that matters is you actually take the treatment. So I think we have sort of run out of time, and I have covered, I think, all of the questions that people have asked. So it is possible to lead a full life, normal life with OCD. You can become a functional person. You can have a very successful career. It's fine. In some careers, having the sort of obsessive personality that I mentioned may actually be a beneficial thing for some people. Let's say you're working in a nuclear plant or something like that, and rechecking may be a positive trait there. But again, that is an obsessive-compulsive personality, not OCD, as I've told you. So OCD, yes, there is hope. We do hope that you would reach out to your nearest clinician. If you would like to know more about TMS, you can follow the Instagram channel. You can message, or there are phone numbers available for our Asha Neuromodulation Clinic posted on the Instagram page. You can get in touch with us and we'll help you out. So just one last question. So a number of sessions. So what we follow is an OCD protocol where we give about 18 sessions. So that's about 9 days of treatment. So it's about 18 sessions for Deep TMS. So 2 sessions a day. It takes about 9 days. So I think I will be ending the live stream now. I hope you all like this. And I hope you do join our future sessions too. Thanks for tuning in.